Ladies and gentlemen, my name is Kwak from Seoul National University Children's Hospital. I'm a pediatric and congenital cardiac surgeon. Very happy for me to participate in this meeting. And my topic today is the aortic root anatomy in normal heart and congenital heart disease. I guess most audience here know this topic very well. So I hope my talk could be helpful to remind you a little bit clear to listen the next several lectures by other speakers. So I divided my topic into the three parts. The first part is the aortic root from the morphologic left ventricle, 100%, namely in normal heart. So aortic root is placed between pulmonary root anteriorly and mitral and tricuspid valves posteriorly. And the fibroskeleton is placed between the aortic valve and the atrioventricular valves. And we call the aortic root from the left ventricular outflow tract proximally and to the sino-tubular junction distally. And it has three components, sinuses of Valsalva and annulus and leaflets. The sino-tubular junction is a small ridge of transverse collagen and elastic bundles. It lies at the line of the opening of the free edge of the aortic valve leaflets. The sino-tubular junction's circumference is about 90% of the annular circumference in young. However, it becomes bigger and bigger by time due to the dilatation of ST junction. So it reaches almost 100% or plus in old patients. Sinus Valsalva, the aortic wall thickness of the sinuses diminishes as it approaches the annulus here. And you can see this table, the right coronary sinus has longest intercommissural distance and longest height of the sinuses. Regarding the coronary artery orifice, right side is placed higher level than left coronary orifice, like in this picture. And in systolic phase, the sinus Valsalva is enlarged more than 50% than ST junction. About the annulus, the nadir of the non-coronary cusp is placed at lowest level, and it has a scalloped shape around the muscular septum and membranous and fibrous skeletal septum. The annulus has a usually 10% larger circumference than the sino-tubular junction, and imaginary plane of the annulus of the aortic valve has a 120-degree about angle between with the mitral annulus. So aortic area is a little bit more complicated, but under the right and non-coronary cusp, there is a membranous septum, and his bundle is going around at the ventricular and membranous septum. Non-coronary cusp and left coronary cusp has continue to the aortomitral continuity. And under the right and left coronary cusp, there is a muscular ventricular septum, and this part faces the pulmonary trunk and infundibulum of the right ventricle. You can see the ventriculo-arterial junction from the pathologic pictures. There is some discrepancy between anatomic and hemodynamic junction. So you see the leaflets, aortic leaflets here and attached here, but we call this part is hemodynamic junction. And the anatomical junction means the fibrotic wall of arterial trunk attached to the supporting ventricular structures. So there is a discrepancy between anatomic and hemodynamic junction. So the picture that I showed you before, this picture is a little bit wrong because this picture shows the almost same level of the hemodynamic and anatomical junction of the ventricular-arterial connection part. So this is a summary of the aortic root. The structures all I have mentioned is shown very well. The second part of my talk is about aortic root from the left ventricle, but some part of the aortic root from the right ventricle. You can see this in the patients with a tetralogy of Fallot and double aortic right ventricle, and pulmonary atresia with ventricular septum, and so on. But basically, I don't think it has a specific difference between these patients and the normal population, but we frequently encounter some pathologic situation like this. So this picture is from the patients with my colleagues, Dr. Sung-Kyu Cho. This patient underwent pulmonary valve replacement a few days ago. This patient has a dilated ascending aorta, and then you can see the right coronary artery crosses the anterior part of the heart. This is the lateral view of this patient. And in addition to the ascending aorta dilatation, the coronary artery's opening is somewhat different from the usual position. Coronary artery's origin usually placed like this, but this patient's right coronary artery is placed a little bit left, and left coronary placed a little bit more right. From the ventricular view, the coronary artery opening is clockwise rotated. So we have to be very careful to reopen, especially for the patients requiring reoperation, not to injure the right coronary artery like this. And also sometimes this kind of patients shows some ischemic symptom by compressed the coronary arteries between the great arteries, or like this, seems like intramural course. The final part of my talk is the aortic root from the right ventricle, and also I think we should think about the pulmonary root from the left ventricle. We can see this kind of morphology from the patients with the transposition of great arteries. So pulmonary arteries is usually placed in front of the aortic valve, and regarding the pulmonary root, it attached exclusively the ventricular muscular portion, while the aortic root is attached to some part of the fibrotic portion of the ventricle, and as well as the muscular portion. So the pulmonary root is freely standing above the subvalvular muscle cuff, that means conus, is the basic concept of the Ross procedure or other aortic translocation procedures. So, however, the neo-aortic root changes some properties late after arterial switch operation. This study shows some changes of the mechanical and morphological properties of aortic root and arch late after ASO for the patients with the TGA. This study was performed by cardiac MRI, and the authors found out the dilated aortic root and more fragmented curvature of the ascending aorta with the acute angulation of the aortic arch, and also they revealed the decreased distensibility of aortic root structure. So you see the figure A shows the normal configuration of the aortic root and the aortic arch, but figure B shows the enlarged aortic root and also acute angulation of the aortic arch after the arterial switch operation. Probably it is due to the posteriorly transposed aortic ascending aorta after the Ruconta maneuver. And this graph shows the changes of the pressure characteristics, that there are two peaks, and also the decreased distensibility means the dysfunction of the the neo-aortic sinus portion. So the changes of the changes of the area range is decreased in this patient. So why this happen in the neo-aortic valve or aortic root? That means naturally pulmonary valve or pulmonary root. So in the patients with the TGA, their natural pulmonary valve or pulmonary root, still naturality of the pulmonary valve or pulmonary root, even after the arterial switch operation. So try to seek the answer for this question. I searched some papers about the aortic translocation or pulmonary root translocation procedures, but all the authors mentioned they harvest the aortic root or pulmonary root from the morphological wrong ventricle, just like when they perform the Ross harvest the pulmonary root during the Ross procedure. There was no mention about the morphological or differences between the aortic root from the right ventricle with from the aortic root from the normal ventricle, means the left ventricle. So I would like to ask Dr. Chang-Ha Lee, an expert in this procedure, so if he found out any difference or characteristics of the aortic root from the morphologic right ventricle with the aortic root from the normal ventricle. Yeah. So this paper is about the reoperation for neo-aortic root pathology after the arterial switch operation. The authors performed the Bentel procedure or valve-sparing root replacement procedure, but they are concerning about the neo-aortic valve function because these patients' neo-aortic valve deeply inserted more than the normal population. They thought there was a more than 10 millimeter of gap between the nadia of the cusp and the ventriculo-arterial junction. So it seems not possible to encase the complete root by their graft to prevent further aortic dilatation. This is their concern number one, and concern number two is about the neo-aortic valve. That means the original pulmonary valve, the quality of the leaflets. So I quickly reviewed CT scans of my own patients, TGA, and some other patients with normally positioned great arteries. So I have not exact data because of the quick reviews, but I felt some tendency of the neo-aortic root placed deeper than other patients. So I agree with the author's opinions. This picture is my own case after the arterial switch operation, and I performed the valve-sparing root replacement. You can see the Recomte maneuver by Recomte maneuver anteriorly positioned pulmonary artery here and enlarged aortic root here. And as the previous author said, I also found out the significantly degenerative change of the natural pulmonary valve, neo-aortic valve. These patients strongly did not want to take anticoagulants. I tried to repair this aortic valve. Unfortunately, after repair, the regurgitant of aortic valve is slightly improved, and the operation was done with only valve sparing root replacement. So just like summary, normal is normal, but normal is sometimes not normal when it is placed in the wrong place. So I started my operation more than almost 10 plus years ago, but still the long and winding road to learn are hard. Thank you very much.